I would now like to introduce our next speaker, Mel Houser, who is a family physician and founder and executive director of All Brains Belong Vermont, a nonprofit organization in Montpelier, Vermont, with a mission to support the health and belonging of people with all types of brains. All Brains Belong has pioneered an innovative model that integrates medical care with social connection, employment support, and community education. Please welcome Dr. Houser.
So we're going to be talking about not only some practical strategies for delivering primary care in a way that works for patients with all types of brains, but I'm also going to be inviting us to think about the lens through which we're practicing. And at least for me, it has required a lot of unlearning the way I was trained and the way in which that my medical training has impacted my interactions with patients. I hope that maybe I plant some seeds of some practical things that can be done even in settings where the system is feels less flexible. I have no financial disclosures. Before I describe what we do at All Brains Belong and some practical strategies, I want to review the literature on barriers to healthcare access, at least for autistic and ADHD patients, and if we can think about and extend what we learned there, that maybe there are patients with many different types of brains who encounter some of these barriers. First, a little bit about me. I'm a family physician. At this point in my career, I am mostly working with neurodivergent kids and adults, often multi-generational families. And though I have a bunch of professional training in this regard, what I have learned the most about brains through is parenting. My 7-year-old, I'm partial to say, is the world's wisest 7-year-old, and who has taught me so much more than my medical training has about the lens of neuroinclusion. So on the left is a picture of me a week before I became a parent. So there I am, a doctor who takes care of babies. I thought I knew what I was doing. Well, my baby thought otherwise and let me know in no uncertain terms that their little baby access needs were not being met. My environment was a poor fit for their needs. The world was too bright, too loud, moved way too quickly. And they let me know by screaming all of their waking hours for their first 2 years of life. And thus began my journey of learning and unlearning a lot of the things, a lot of the defaults that, not only did my medical training teach me, but that, society, the messages that had been, ingrained for decades. As it relates to autism specifically, this is what my medical education looked like. So in the preclinical years, I got a 1-hour lecture. It focused on the triad of impairments and a rote list of co-occurring conditions. Just, yep, these are the things. These are the things that go along with autism. Okay. And in my clinical training in medical school, it really was limited to stereotypes. There was an emphasis on red flags, prevention, treatment, and it was implied that this was rare. And though I didn't have a lens for this until, more than a decade later, the hidden curriculum that there is one correct way to develop. This is the hierarchy, the developmental hierarchy. This is what you do by this certain point. This is the one correct way to develop, to play, to learn, essentially be a human. We know, of course, that that's not true. What we know in 2024 is that we all have different brains. We all have different ways of sensing, processing, thinking, behaving, communicating, learning, etc. Neurodiversity is like biodiversity, the natural variation in human neurocognitive function. We all have unique patterns of strengths. We all have things that are more challenging, which is why universal design, that is offering everything you do in multiple different ways and give people freedom and choice to pick what works for them, that is best practice. And short of this, it's about focusing on designing supports and accommodations. It's not about treating or fixing or complying with the neuronormative defaults. What we know is that one size fits all does not work for all. Anytime there is a default, anyone whose brain works differently from that default is far more likely to be othered. So when we think about the defaults of the healthcare system, you must pick up the phone to make an appointment. You must fill out the 20-page packet to become a new patient. There are a lot of defaults in the healthcare system. So I want to review the literature on the status quo of healthcare for autistic patients. What we know is that nearly 80% of autistic adults have difficulty accessing primary care. Not surprisingly, the overwhelming majority of autistic adults have untreated health conditions. We don't get very good training typically in working with autistic patients. This study, Nicolaitis et al. In 2021, only 25% of US primary care physicians were competent with communicating with autistic patients. Less than half competent with making an accurate diagnosis and treatment. So training is not good, confidence is low, and outcomes are poor. Been several studies that have looked at what are the barriers to healthcare access for autistic patients, and they cluster around these three buckets: the environment or interactions with the healthcare environment, including relating to sensory processing, communication with multiple members of the healthcare team, barriers from the provider, including the perception that healthcare providers have insufficient knowledge and skills and unhelpful attitudes that interfere with providing care. That's the perception of patients. And barriers from the system. I mentioned the defaults. But also the culture can have defaults. There are all kinds of hidden messages. I think about in my training, the way that I'd follow a resident around, and somebody would say something like, "There we go again, another patient with the list," as though there were something wrong with organizing your thoughts in writing. Or, "Oh, that patient has a positive cell phone sign. They can't really be in pain," as though one can't operate a cell phone while they're in pain. So again, just unlearning so many of these messages, because they are a barrier to healthcare access. When we think about the social model of disability, for the past 25 plus years, the World Health Organization has defined disability according to the social model of disability, or rather than the medical model, rather than thinking about, well, the problems are all with the individual. It's really about the amount of disability someone's going to experience is relative to the barriers in the environment. If I had a visible disability, like if I were a wheelchair user and I approach a building that has a ramp, I'm going to have less disability than if I approach a building that does not have a ramp. And so it is with invisible disability as well. And so when we think about so many of the equivalents of not having a ramp within a healthcare setting, that's not why we're talking about this. We're talking about this because neurodivergent patients are dying. Autistic adults have an average life expectancy of 36 to 54 years, with leading causes premature cardiovascular disease and suicide, with autistic adults having a 4 to 9 times increased risk of completed suicide. ADHD adults also have a 4 times increased risk of premature death. the status quo of healthcare is failing neurodivergent. So for me, when I learned this, it was a hard stop. At that point in my career, I was mostly taking care of neurodivergent patients. I didn't know that. I was mortified that I didn't know that. And I had just learned that I'm autistic. I was 37. I was the parent of a 4-year-old autistic child. And when I learned that the average life expectancy was 36 to 54 years, that was profoundly unacceptable to me. And so I quit my perfectly stable job and started All Brains Belong, or a nonprofit organization, launched a little over 2 years ago, with the idea that healthcare is more than medical care. We think about, here's a person, what are all the different ways we can support them? Providing direct services, but also wrapping around them and thinking about how, if someone has trouble making friends, trouble keeping a job, trouble accessing their education, how will we be getting them healthy? Because all of this is part of health. So our model here, we integrate medical care into all of these other buckets. And we try to deliver things with as close to universal design as we can. And most importantly, we are building a community. Patients come here because they are looking to connect with other patients. Most of the people who come here, they come here because their needs were not met by the traditional healthcare system. Most people come here because they are extremely isolated and they have not had the experience of being able to show up and connect with other people, and they don't know how to do that, and they've never felt safe doing that, and it's never really gone well for them before. So that's part of healthcare here, because connection can be such a transformative experience that can really have a profound impact on someone's journey. Really, what we've formed here is a community health village of learning and healing together. As I said, patients come here because they need something different. And what we find is that by bringing people together, they hear their stories reflected back to them through the stories of other people. And that allows many people to shift their own internal narrative, the way they see themselves, the way they see their future, which becomes a lot more hopeful, and they feel a lot less alone. So as I said, we've been at this for about 2 years now. We're a small practice, but in our first 2 years, we've served 339 patients. And our community programs, which are open to everybody, not just people who get medical care here, and most of them are virtual. So I'll tell you more about things that you can connect your patients with. It's just the idea of improving health through this novel delivery system, where it's about community connection. I'm going to tell you a little bit about the logistics of how we do things here. So we care for toddlers through older adults. We take insurance. Most of our patients have Medicaid, Medicare, and so it's a novel system, but is using existing systems. It's not like opting out of health insurance or anything like that. We just see the patient same way that we would in a traditional setting. Our scope of practice. So in addition to primary care, we have a non-primary care track where folks come for support around medical conditions more common in neurodivergent patients, including hypermobility spectrum disorders, including hypermobile Ehlers-Danlos syndrome, mast cell dysfunction, POTS, dysautonomia, long COVID. What we found, because all of our programs are informed by the community that we're serving, and what we found is that these were huge unmet needs. And we really wanted to be able to expand access to things that people were having a hard time accessing support for within their primary care medical home, that they had very good, long-standing primary care relationships, but that there were things that were not well understood by the traditional system. And so that's why we created this non-primary care track. And that also included gender affirming hormone treatment for adults. We very intentionally do not look and feel like a traditional healthcare setting. A lot of the patients who come here have had a lot of healthcare trauma, and they walk into an environment with the fluorescent lights overhead, and they're what lives in their body is the memory of the time they were restrained as a child, like all of these things that have accumulated in their nervous system. We very intentionally, it looks more like a living room than a medical setting. I want to share with you some themes of what we've learned in our first 2 years. As I said, healthcare is more than medical care. And what we find is that when patients are able to show up authentically and feel connected to and understood by another person, even energetically, that's where we really start to see improvements in medical conditions. Because, we know, for example, that social isolation has the equivalent harmful impact on health as smoking 15 cigarettes per day. And that's why that is so important. There is no one right way to think, learn, or communicate. Very early in our tenure, we're open maybe about a month the first time we did a statewide COVID community vaccine clinic. Kids and families traveled from all over the state of Vermont, 2.5 hours each way, because they were not able to access vaccination at their primary care medical home. They were not, or the malls and the gyms and all the things that COVID vaccination were typically being offered at that time. And so what we did was we created a menu of all of the different things that someone could have agency to choose from. Whether you were a speaking communicator or a non-speaking communicator, you had this menu and you co-created a customized vaccine experience, because that's what we do in our medical practice. So all of the patients are provided a menu of flexible things that they can co-create their healthcare experience. So things like you pick your lighting, your furniture, the way you wish to communicate during appointments, between appointments. You choose from a range of sensory supports, executive functioning supports. The way even when I talk about communication, we have many patients who, the idea of showing up and being expected to produce your history at a certain time within this limited span, that doesn't work for all brains. So the idea of just normalizing, if you want to prepare something ahead of time, you want to draw pictures, you want to come into the exam room and text us from inside the exam room while you're sitting next to me, that's great. However you best communicate, because there is no one right way to communicate. I forgot that there was a slide that said what I just said. So maybe some of the other things I did not mention. So setting, how simple it is to offer the opportunity to have an outdoor visit, to go outside and sit on the grass. And there's many people who that is such an important piece of nervous system regulation, that we're really able to, communicate in a way that we really wouldn't have been able to when someone did not have full access to their cortex. I think it's just really important to remember that safety comes first. Safety is that basic prerequisite. You got to feel safe before you can be regulated, and you got to be regulated before you can do any of these higher order things that we are expecting of people when they come in for a healthcare appointment. So where did this menu come from? So building on what came out from research, I just really wanted to draw some attention to the really incredible work from Autistic Doctors International. And so the studies on what are the barriers to healthcare access, well, why don't we just design a menu that addresses the things that have been shown in the literature that are barriers? Yeah, let's do that. I also want to draw attention to the Aspire toolkit, really a wide range of tools that are really quite helpful. And so things that supports that are known to be helpful, we brought that to our community. We had focus groups of folks in our community about which of these things do you think would be helpful to include in a menu, and what else do you what do you wish existed? And so our menu really came from input from patients. We have a community advisory board that gives feedback on all of our programs, healthcare programs, community programs, employment support programs. It's really about asking the community what they need. It's the idea of, while there's, I think many people would acknowledge that there's a lot of things about the healthcare system that don't work for lots of people. Sometimes it's like, well, there needs to be some big changes, some big structural top-down changes. And those are important. And it's not the only way. Systems change from the ground up, bringing people together, thinking about some simple, sometimes free ways that you can do things differently. That systems change also. So very early on in our history, we noticed a pattern. We noticed a pattern that the patients who, again, not to say that we have a homogenous group of patients by any means, but certainly the people who were coming here were people whose needs were not met by the traditional healthcare system. And among that group, 95% of those patients have a constellation of intertwined medical problems. You might remember at the beginning of this talk, I mentioned, back in medical school, we got the list of co-occurring conditions. Well, I never really thought about how those things might be connected. You just memorize, oh yeah, those are the things, and you see them and you spot them and it's pattern. Oh yeah, we know that those things are linked with autism, for example, or ADHD. But really, this is a constellation of intertwined medical problems where sometimes the standard management of some parts of this constellation make the other parts worse. And I think when I was in traditional primary care, I think this pattern got diluted because it was a general primary care practice. But now with a self-selected group of people, mostly autistic and ADHD people whose needs were not met by the traditional healthcare system, now the pattern really jumps off the page where, for example, if someone with chronic pain is prescribed a muscle relaxant, but they actually had a connective tissue disorder, like a hypermobility spectrum condition, now the muscle relaxant made their floppy connective tissue floppier. And oh, by the way, their undiagnosed obstructive sleep apnea, now that muscle relaxant made the sleep apnea worse, which made the pain worse, which made the dysautonomia worse. And I think this is what goes on out there. So I think this quote really said a lot. This came from a patient of mine. It's like a ball of yarn. If you pull the wrong string, you make the knot tighter. You have to find the right string to pull. And I think the healthcare system thwarts us as clinicians. It thwarts us, you must do the thing in 15 minutes. 15 minutes, it's so, and I mean, it's so hard to zoom out wide enough to be looking at not just like one problem or two problems, but all of the problems all at once through a unified lens, because I think the art of this is about finding the strategies that make some parts of this constellation better without making the other parts worse. So examples of some of the conditions that are part of this constellation, I mentioned some of them. I'll let you read the rest. And certainly this is not an exhaustive list by any means, but these things are common. And the ways in which these things interact is really interesting. So for example, we have a lot of patients. We know that autistic and ADHD people have higher rates of long COVID. So, not surprisingly, we have a lot of long COVID in this practice. But we've been able to really make a lot of improvements by managing mast cell disease. And also getting chronic pain better through the management of mast cell disease and endometriosis and migraine. And so it's about recognizing the relationships between these things, because there is literature that links not just autism and ADHD with each of these, but literature that links each of them to each other. But it's about zooming way out. This is, looking at the whole picture all at once. Again, finding the things that support some aspects of this constellation without making the other parts worse. So I just want to let you know about this free resource. So with support from the Organization on Autism Research and HRSA's AIRP grant, we released a free resource over the summer. It's been accessed by more than 10,000 people so far. And what I'm really proud of is that this was co-created with input from more than 100 autistic and ADHD patients in our community. So it's integrating evidence-based practice with lived experience. And that's the main page. And I think that I was going to be ambitious and like start typing while talking, but I don't have the kind of brain that can do that. You'll see on this main page, there's a link to clinician resources, and that has this comprehensive peer-reviewed guide of each part of this constellation, and some strategies for identifying and working through some of these problems together with patients. As I said, connection is the path to health. And what we, again, have found is that when patients have the experience of connecting with other people, we do a lot of group medical appointments in my practice. And, I think there's many folks who are overwhelmed. They had not necessarily put the pieces together, but the idea of when there's multiple other people who are going through similar health journeys, that really can be transformative. As I mentioned, in addition to our medical programs, we have social connection programs. Most of them are virtual. They are open to everyone, everywhere. This is a program called Kid Connections. It's free. It's a customized friend matching program for kids aged 3 to 17, although slightly older teens and young adults are also welcome to participate. It's the idea of connecting people based on shared interests, not a shared diagnosis, but shared interests. If you're a 10-year-old with a monotropic focus on dragons, we're going to find you another peer who loves dragons as much as you do. And we ask all kinds of, so participants and their caregivers or support people can fill out this profile about their communication profiles. And so we're making a match based on shared interests and communication profiles. And it's been really humbling, for kids and teens often to make their first friend. This is a quote from a participant a few months ago, 16-year-old. So this must be what it feels like to finally have a friend. Humbling, like heartbreaking and humbling at how truly not that hard it is to help people feel like they belong. We have a program called Brain Club every Tuesday night at 6 p.m. Eastern. It's a free community education program about everyday brain life. And so every month has a different theme and different topics within the theme, and it's all recorded if you can't make it live, and the archives are all available dating back the past 2 years. This week we had it was a pretty cool program. We had a panel of primary care physicians from the traditional system talking about that everything's connected to everything project I showed you with the constellation of intertwined medical problems, and what it was like for them to learn about the project and kind of start spotting these patterns in their patients and using some of the strategies that they learned in the guide. So it was a pretty neat conversation, because Brain Club is attended by professionals and the general community, and it led to a really neat conversation to follow, and really like bridging the double empathy problem, where often sometimes I think it's this mismatch of communication style, double empathy problem. If you've not heard that expression, that's a term coined by Dr. Damien Milton, who's an autistic social scientist in the UK. And it's the idea that there's not one normal type of social skills, and then, here's the autistic people over here. It's really about the communication breakdowns that happen when there's a mismatch between communication style and worldview. And so I think Brain Club very often is about bridging the double empathy problem. Employment support programs. We know that autistic and ADHD people have far higher rates of employment challenges. 75% of ADHDers have challenges with employment. Autistic adults are 4 to 8 times more likely to be unemployed. And given the relationship between unemployment or underemployment and health problems, for example, there's one study that showed that unemployment increases the rates of chronic disease by 83.1%. Whoa. So when we launched 2 years ago, we didn't have employment support programs, but within the first few months, our community advisory board, really the feedback was they wanted to talk about work and how work was not working for them. Namely, it was really hard to find work. And we know that one size fits all does not work for all. And so if you, because of your disability or otherwise, the idea of work has to look like this, well, that's not accessible to me. So now it's not like all or nothing. And so we started employment support programs with the idea that, what would it be like not only to help people learn about their employment related access needs, but also to provide them with not only being connected with other employment support resources outside of All Brains Belong, but we even, one of our programs, we helped a small group of patients who were unemployed because of disability. We helped them start small businesses, and we provided them with paid opportunities for project-based contract work. And it really, again, was not that hard. I think by and large, one of the most powerful things that we do for patients with and without intellectual disability is to introduce this frame of access needs. The idea that, access needs is anything required to fully participate in one's environment or community. Everyone has access needs, people with all types of brains. And so it's the idea that your access needs are by and large more or less likely to be met depending on those gaps in the environment. And when we think about access needs and employment, they're vast. There's so many different things. And so really digging into these things, diving deep into these things, and helping people have a way of thinking through that, so that when they are thwarted by their environments, they can recognize that that's what's happening, as opposed to the default narrative, which is, it's my fault. I'm struggling because there's something wrong with me, as opposed to the environment thwarted me. Again, I just want to wrap up with 2 quotes. I'm going to show you this quote, and I'm going to play a quick video from a patient of ours who participates in all 4 of our buckets of programs. All Brains Belong has helped me uncover what is standing in my way of offering my gifts to others, gifts that I have longed to offer my entire life. I am learning why I'm meant to be here.
An opportunity to meet others in the community who are going through the same or similar things, which then gives us the opportunity to learn from each other's experiences and to really value and feel valued by each other and feel a lot less alone and a lot more hopeful. And so it ends up feeling like a community more than a medical practice.
What I often see is once people feel safe and once people have been cued safety, they're able to engage in community. And that's when we really see these kind of healthcare jumps for people. We see, people come to group visits and learn from other people and have that shame reduction of, oh, it's not just me dealing with all these things. There's other people who believe me, there's other people who are like me, and get really quality medical care too.
To be in a community where I get to explore and learn about my brain and other people and other people's brains.
We're all in this together as individuals that, that sees things differently, hears things differently. move things differently.
Smoothing out the rough edges of my experiences and of my perceptions. I'm less harsh on myself. I'm less sharp with myself, right?
It's exposing me to people being so beautifully raw and authentic because the space allows that. And I can't think of many spaces in life that allow for people to come together in this way and kind of like this radical act of trust.
ABB to me has been a way to have community, have social connections, to understand my body, to reframe mental illness into, autism, to medicines that, simple medicines that have been able to make my mobility and my ability to be in the world different. ABB has given me a way to be myself and in community with others that I hadn't had in so long.
What do you mean healthcare can be like this?
If anything you heard for today resonated with you, we'd love for you to get connected. Again, we've got plenty of free community offerings. Anyway, I'm also happy to take questions.
So, hi, thank you so much for an amazing description of an amazing practice. And I'm still trying to wrap my head around how does one do this? But I think one of the key terms came from the video, which is the word community. And you've created this space for community, and the way that we see patients in traditional clinics, it's not really so much community as sort of a one patient after another, and it's a very different type of practice.
I remember this day it was one of my last months in traditional primary care, and I saw an 8-year-old autistic patient with a monotropic focus on Pokemon, and he had no friends and was getting bullied. Mm-hmm. And then right after him, I saw a 9-year-old autistic boy with a monotropic focus on Pokemon, and he had no friends and was getting bullied. And I had this thought like, this is madness. Why can't I introduce these kids? This is madness. And so it turns out, the brain rules of HIPAA, like if people give permission for stuff, you can reimagine what healthcare has to look like, because the single most important things that I did for either of those children over the course of their time being my patients over the past 5 years is introduce the two of them together. Now they have play dates, they're friends.
Great, thank you. So there are a number of questions in the Q&A, so I'm gonna ask you the questions. So the first question is about housing. Finding safe, accessible, quality housing is such a challenge, especially for people with disabilities. And do you provide resources around housing?
Not yet. I mean, what we do is we connect people to local organizations that provide housing support, but it's a lot of like they connect you to be on a wait list for things, as opposed to what really needs to happen is the idea of interdependent communities, and that doesn't exist. And I absolutely agree. That is so important.
So the next question, I will read this to you. I have the opportunity to participate in a variety of communities as a parent, behavioral health specialist, and professional who supports individuals with IDD. What I have found is each group is having their own conversations that are all parallel to each other. Do you have tips on how to help professional groups talk to each other, I think, and join forces to address these parallel issues? Sometimes it feels as if everyone is doing their own thing, often reinventing the wheel. So I think this is sort of the silo, many silos.
Yes, the silo thing is so unhelpful, and that's what goes on. So I do I have a magic solution for breaking down silos? No, not at all. But I think it starts with just naming that. and for any individual that does have connections outside of the silo to try to make those connections. And so, hey, did you know about this other group having this conversation, or this network, or and maybe it's about, what we try to do here, like at Brain Club, what we try to do with community partners. Periodically, we'll have community panels where people outside of the All Brains Belong Village will come and talk about their work at Brain Club. It's the idea of like, not only are the people here then able to learn about other services and resources and programs, but now the people who came to present, now they know about what we do, which and they see the relevance of what we do to what they do. It's really about like finding those intersections, right? Because you sometimes have to make that point. Like sometimes I'll even have conversations with like people who work in substance recovery space. They don't know that what I do connects to what they do. Or people who work in the suicide prevention space, they don't know that what I do connects to what they do. And so, because they've never thought about it before, that's all.
So the teachers are learners and learners are teachers and all of that.
Absolutely.
Okay, so just a couple other questions. So one is around universal design, and I think you've talked about this, and it's really about tailoring care to the specific needs of each of your patients. And I guess my question to you is, it seems like it might take a lot of work, but what do you think? Maybe in the long run, it actually it takes even more work if you don't do it.
Exactly. When I do trainings for healthcare practices, one of the things that I start with is, once they get introduced to like the concepts that you all got introduced to today, is the idea of like, let's map out your patient's workflow. These are all of the different places that a patient or their family or their support team interfaces with. And let's think about, do you have any defaults? One way of doing the thing, and can you introduce at least one other option? So for example, the waiting room. The patient comes in, like forget all the stuff that was really difficult and obstructive that interfered with them even making it to the waiting room, but they're in the waiting room now. You have one waiting room, one place to wait. What would it look like to give people the opportunity to choose between waiting in the waiting room or waiting in an empty exam room? Or even better, waiting in their vehicle and until you're ready for them. Like, so now we've got 3 choices, and that didn't cost you anything to do.
And as you're speaking about this, I'm thinking that not only is this a good system for people who are autistic or with ADHD, but maybe for practically everybody.
That's right. And thank you for naming that, because I think that what is different here is we're not necessarily, we're not I was gonna say not necessarily, we're not at all waiting for someone to disclose a disability before they're offered the menu. The menu is offered to everybody because universal design benefits everyone. And so, for example, being able to offer, and this might not be, it's not necessarily every professional has autonomy over, the technology stack of their organization, but the idea of having multiple ways of making an appointment. So to be able to, self-schedule online versus call versus email or whatever, that benefits everybody. And so that's just, yes, so I could not agree more. So just the idea of, the other thing about the menu is that patients don't know what to ask for. So it's one thing if you said, hey, patient, what are your access needs? They don't know how to answer that. Like no one's ever asked them that. They don't know what that means. But the idea of here are all the different things we offer that you can choose whether you want bright lights or dim lights. You can choose, again, the places to wait. You can choose whether you want a video summary or a written summary or a graphic summary. You can choose whether, like just thinking through what are the things that I actually can offer that I do have autonomy as a professional to be able to offer.
And thank you. And my final question, it's sort of the systems question, but I think I know maybe the answer to this, which is that all of this is probably so difficult to do within a very rigid structured system, because there's so many people who say, no, you can't do that. Any comments on that? Although most of us work within systems, so it's hard to sort of get out of the system.
It is so hard. The system thwarts everyone. The system thwarts patients and clinicians alike. I would say that, truly, I felt like I had to break free of the constraints of the system to be able to do some of these things. And that doesn't mean that you can't do some of these things within the constraints of a rigid system. Especially if you're not directly challenging the system's rules. So it's like the oblique angle. These are the things that the system's not really thought about. There are no rules that say that I can't actually offer people to be able to wait in their car, and I can just work with my medical assistant and we just make that happen. As opposed to needing to like change your electronic system so that you don't have a patient portal that people can't remember their password for. So that's like a big change, as opposed to a little change, or things like that.
Sorry, that looks like there's a couple other questions. Is that okay, Clarissa?
Sure.
Okay,
Yeah.
all right. So, and I'm asking Clarissa because she's
You're good.
Okay, so I think one had to do with compensation. One of the barriers for providers wanting to see people with disabilities is the compensation they receive, given that time is spent on them. Compensation is a big deal, especially in private practices when they have an overhead to consider.
Yeah, I mean, that is real, and I think it's about, again, there was some intentionality to the way that because again, it's harder to roll back your overhead than to build a low overhead practice to begin with. And so the idea of like thinking about, all right, well, what is and this is literally what I did, was the thinking about, all right, let's assume every patient has, has at the lowest reimbursing insurance, which in our system is our state Medicaid payer. So let's assume all the patients have Medicaid, and let's figure out what is the bare minimum number of patients that I would need to see in order to pay my rent. Okay, well, what about to pay myself? What about to hire someone to do my faxing for me? So I like built these tiers. I'm like, oh, I actually could actually hire somebody. That's so interesting. And so it's just the idea of the things that happen in between appointments. It's about transparency. So my patients know that we have intentionally structured that they can get appointments as often as they need it. But that also means that everything happens during appointments. So if we want to like strategize about a letter or a meeting for school or whatever, we're going to do that during appointments. And that's how I do that. All the things that need doing, they're actually part of medical care. So we do that within the container of appointment.